What is rehab or rehabilitation? My name is Fred Bagares, a board-certified sports and spine medicine physician in Virginia Beach, Virginia. After 10 years of practice, I still find musculoskeletal medicine both fascinating and challenging. This podcast is about the lingering thoughts and questions I've had after residency and fellowship. My hope is to spark discussion, challenge dogma, and share my experiences in musculoskeletal medicine. Welcome to the Talking Rehab Podcast. Setting expectations is really very important when it comes to patient care. I recently had a patient with a 2 to 3 month history of left shoulder pain. They didn't do anything in particular that caused it. They just kind of essentially woke up with a sore shoulder. They think they might have had a misstep or bumped it or something, but nothing obvious, nothing like a major fall or something running into them, nothing like that. But this injury occurred probably a couple months ago, and they did see their local sports medicine doctor. They ended up getting an X-ray, no fracture. They referred them to start physical therapy, but they were not able to for various reasons, and they ended up with an MRI of the shoulder, which did not reveal anything concerning. This person is over 60 years old, and they had, essentially kind of the typical findings. There was some evidence of AC joint and glenohumeral joint arthritis. There's evidence of partial thickness tears of the rotator cuff. That being said, in our conversation now 3 to 4 months down the line, they are still hurting. And the question is, well, why are they still hurting? That was their direct question to me. Or they expected it to go away, but it hasn't. So why is that the case? And I answered it from a couple different standpoints. Number one, with this type of injury, there wasn't really an inciting event. It just essentially kind of started hurting. And the main problem is they have impingement symptoms of the shoulder, meaning when they reach overhead or reach in front of them, they develop pain essentially in the front of their shoulder. And that particular pain syndrome can come from a variety of different things: AC joint arthritis, subacromial bursitis, rotator cuff tendonitis, tendinopathy, rotator cuff tear, bicipital instability, kind of the list goes on and on. And when you add in the feature of an MRI, someone over 60 years old, you're going to have a lot of different findings. So the picture can get kind of muddy. So the way I answer that question is really, it's hard to know exactly what is the cause of the pain. There's also the assumption that the pain is coming from one thing, meaning like it's just the partial thickness tear or it's just the arthritis. It can be very difficult to tell what pain started in the beginning and what pain is present now. So this particular person focused primarily on the partial thickness tear of things, and partial thickness tears are very common. You see them in very young people. It is expected with time and age for the rotator cuff to have certain changes, and partial thickness tears are one of them. So we don't typically jump to surgery for this particular issue, but again, the question still remains is this the actual problem? Now, in terms of the timeline of a partial thickness tear problems can take, anywhere between 4 to 8 weeks, I think is a reasonable amount of time to resolve things with a conservative treatment approach. Even just watchful waiting, I think just seeing how the shoulder does. Time does a lot for the body, and I think that sometimes is underappreciated. When people end up having pain and disability to the point where they can't do day-to-day stuff, that's where injections can sometimes be helpful. And this particular person was referred to physical therapy, but just couldn't for certain life reasons. And we started talking about, well, what about the injections? And again, the main question that they had was, why is it lasting this long? And The short answer is that we don't really know. It's even though I've outlined the expected timeline of pain to resolution with a partial thickness tear, it is that same timeline for essentially any of the conditions of the shoulder. We expect most shoulder problems to be non-surgical and to resolve within, I would say conservatively within 8 weeks. But what I have learned with time and experience is that sometimes injuries, when you have parts that have degenerated or there's tears or there's arthritis, when pain symptoms start and the parts are no longer new, it often takes longer for things to resolve. So when you're 20 years old, you get a hit into the shoulder. Most people, their parts are still fairly healthy. There's no degenerative changes. Structurally, everything is intact. Those folks tend to resolve their symptoms sooner than later. And that may not necessarily be exclusively as a result of the parts being new, but we know that having, older parts, sorry for me to say that, but having older parts doesn't usually mean that people resolve things faster than they used to. So setting that expectation of no matter what the actual cause of the symptoms actually is, the main discussion point I had was the fact that pain symptoms with degenerative parts usually linger longer than if the parts were quote unquote normal in appearance or younger in appearance. And it's very important to explain that to people, because the next question they had was, well, if we don't know that the partial thickness tear is the actual problem, it doesn't mean that that it's not. So if it does eventually need a surgery, what is the expectation? So sure, the pain could be coming from that, and it can respond to a surgery. They don't typically necessarily repair partial thickness tears. They may do a subacromial decompression and try to alleviate any friction within that space. But even post-surgically, recovery is different in my experience. When you're 20 years old versus if you're 60 plus years old, even with a non-repair type surgery with a surgical decompression, people take longer to recover. So I have a tendency, aside from, me being a physiatrist, I obviously have a non-surgical bias. But I do have that appreciation of the value of keeping the shoulder as active as possible, no matter what the actual cause of the symptoms is, because there is a cost to not doing anything and just watching longer. This particular person was still having pain, had fairly good range of motion, but the main issue is that they missed out on their sporting season. They like to play golf, and they had to essentially miss the golfing season because of the shoulder problem. So one option is to actually start therapy and try and move and see how far you get. But there's still the discussion of like, well, maybe we need to do surgery first and just save time. And that's not always the wrong answer. I've definitely had some conversations with other non-surgical specialists, physical therapists, sports medicine doctors, that some people, they are just like, surgery is the no surgery ever for this particular condition. Some people can be fairly dogmatic, but honestly, I'm not as hard set on it has to be this way. These conditions, should never be operated on, because ultimately it does come down to the patient and their timeline. If this person is trying to meet the golfing season, and we know that a post-surgical recovery can still take somewhere between 8 to 12 weeks, and that's not even counting trying to learn how to swing a golf club again. Sometimes now is better than later, because you can imagine the frustration of the patient, where if they do everything you say, start off with physical therapy, that's typically somewhere between 6 to 8 weeks, or let's say 6 weeks conservatively. Then they follow up. The pain is still there. They get an injection. That's the steroid injection. works a little bit, but let's say it wears off in 2 weeks, and now they're up against a now their symptoms are still there. Surgery is now on the table, but the surgeon does not want to operate on them because of the recent steroid injection. They try not to operate too soon to the last dose of steroid because of concerns of post-surgical complications, which is of course warranted. But to the patient again, let's say that they end up getting the surgery, it's so much further down the line than from when we started, and then they miss a second golf season. So it's not a very clear cut picture. I think that is sometimes lost in the medical research discussion. Everyone goes by the book. I really think that is sometimes a factor that we've lost as clinicians, or we fail to appreciate. But at the end of the day, setting appropriate expectations for the patient is paramount. You have to let them know how long symptoms can linger and whether or not it's normal, whether or not it's a sign of injury or damage. That's how you actually manage this type of stuff. You don't just say, "Well, it's not torn. I'll see you later." So it was a kind of an interesting, but very common discussion and explanation. I wanted to talk about that in particular with the shoulder because I think each of these conditions has different expectations. So as I come across these cases, I'll try and drop an episode where I talk about how I work through it with my patients. Thanks again, guys. Take care. Thank you for listening to the Talking Rehab Podcast. I hope that this podcast stimulates you to question your own practice and how you approach rehabilitation. I truly appreciate your time and attention. If you enjoyed listening, make sure to like and subscribe to the podcast. I wish you a movement-filled day. Take care.